Hello, this is Dr. David Nace from Innovaccer, Chief Medical Officer, and welcoming you here for our third episode in our webinar series, Using Teams to Drive Value, a Successful Approach to Population Health. So with me, I have two esteemed panelists. I have Paul Grundy, Dr. Paul Grundy, who is founding president of the Patient-Centered Collaborative, distinguished healthcare leader here at Innovaccer, Global Director of Healthcare Transformation at Teamworks, and also a member of the national leadership with the National Academy of Medicine. We also have David Nash, Dr. David Nash, who is the founding dean of the Jefferson College of Population Health with the Thomas Jefferson University. He is also the Dr. Raymond C. and Doris N. Grandin Professor of Health Policy. He is a board-certified internist and internationally recognized for his work around the public accountability with health outcomes, physician leadership development, and quality of care improvement. So welcome, Dr. Grundy.
Thank you.
And Dr. Nash. So without any further ado, let's move on to our overview and brief recap of our prior two episodes. In episode 1, how to empower primary care physicians and teams at the point of care. In episode 2, key drivers in building a world-class healthcare patient-centered practice. So in an overview of our last two episodes, we discussed primary care as a chassis for healthcare transformation, and we explored the issues that primary care is the first touch point for many patients, deeper patient connection, and far more accessible. We reviewed the evidence from some of the pilots that were done and the evolving evidence that's been published to the Patient-Centered Primary Care Collaborative about how primary care drives better care by reducing hospital stays, days in ER use, increasing chronic medicine, and a drop in total cost of care that's of interest to all of us moving into value-based care. Episode 1, we reviewed how to empower primary care physicians and care teams at the point of care. We know it's important to help physicians build a trusting relationship to their patients, and in order to do that, they need a complete and holistic patient record, access to real-time patient data, access to patient-level risk information, real-time prescription data, including opiate prescription given today's current opiate crisis, automation of the care management process, and actionable analytics so that people know exactly the actions they can take based on trusted information they get. In episode 2, we talked about really understanding the needs of your patients in your practice and in your healthcare system. And you can do that by surveying the needs of your patient, having patient-generated data so that you can understand each individual patient incorporated into the overall view of all the data you have. That allows you to build trust with your patient, be more empathetic, and then being able to be supported with real-time actionable insights at the point of care and helping to get the patient engaged in that process using the information that you have available to help them manage their own care plan. That really is the secret sauce going forward, is how to engage physicians in managing their care. So here we are with episode 3, Using Teams to Drive Value, a Successful Approach to Population Health. And we're going to go deep into that with case examples and stories from our panelists. So without any further ado, let's bring up this key question of what is team-based care and why do we care about it? So we know, one definition of team-based care is more than one person. So a physician and say a medical assistant who's working together with a patient in a team-based approach to really understand how to best take care of that patient and use clinical evidence to really deliver the best and highest quality of care to the patient and their family. So with that, I just want to ask Dr. Nash, with your experience as Dean of the first population health college in the country, how do you view team-based care from a population health point of view?
Well, first of all, what a great opportunity to be on this program with you, David Nace, and with my good friend, Paul Grundy. So thanks again for the opportunity. And we're talking about a topic that we have a lot of interest in, obviously, in the nation's first College of Population Health, team-based care. So to get to your great question, what exactly is that? Well, that's a really important question. I guess we believe it's interprofessional, it's technology enabled, it's everybody practicing up to the highest level of his licensure, and it's focused on a measurable outcome. I mean, those are sort of the key criteria of what we mean by team-based care. We'll get into the issues of who's trained to do this and how good a job we're actually doing, but I think those are among the key criteria we would use to define it.
Awesome. So sounds like team-based care is very important. Dr. Grundy, with your work driving the primary care as the foundation for a new healthcare system, how do you view team-based care?
When I started this journey about 15 years ago, and I used to go into a primary care practice, it just broke my heart to see how little time the physician had to actually do what he needed to do. Difficult diagnostic dilemmas and relationships. Spending half their time typing. Not having the visit really organized with a huddle ahead of time, not understanding what really needed to be looked at during that visit. In a team-based care where everybody's working at the top of the license, in the model that Bodenheimer and others have talked about over the years, the medical assistant, for example, moves over to the EMR and acts as a scribe. The MAs are much more empowered to do much more of the exam. So the doctor can really focus his time on the two things he needs to do: difficult diagnostic dilemmas and relationships.
So it sounds like team-based care can really address a lot of issues. And I would think it would also really vary in terms of what is team-based care in different settings. So I'd like to ask each of you, can you give us some brief examples of what a composition of a team-based would look like? What would a team, Dr. Grundy, look like in a primary care practice? Just some examples of configurations.
So in some of the more progressive primary care practices that I've visited in the last few years, there is a nurse educator, for example, in which if it's not a difficult diagnostic dilemma, the primary care physician can tell the MA, we're going to go with, and the patient, we're going to go with a nurse educator who's going to sit down and help you with your diabetic plan for this year. We find that probably clinical pharmacists do a much better job of medication management than the docs do, and that frees the doc up to focus on what they need to focus on. And I think every chronic disease has a behavioral component, and certainly you're not going to get your diabetic better if they're depressed. So, really thinking about a behavioralist as part of the team is really important. And then having the data come in, now that's publicly available in the technology, to give you the social determinants of health. So you're not only understanding, what's happening clinically with the patient, but, what's happening socially with the patient begins to really make an impact on the patient care.
Awesome. That makes a lot of sense. Dr. Nash, given your background as a leader in the population health movement, how do you think about team-based care as it might vary at a system level where there's care managers, care coordinators, physicians, and other stakeholders?
Sure. So I think this gets to the important point we have to tackle, which is who is actually trained to lead this complex team that you just referred to. So if the team has diabetes nurse educators, care coordinators, social workers, community health workers, I have a mental image of a physician sitting at a control panel like in NASA Houston Control, monitoring and analyzing and looking at all of the incoming data, trying to distill the important take-home information from the data overload. So I think this means the physician leader of the future, she is going to need all kinds of new skills: data analysis, team training and team leadership, change management. This is way beyond the individual doctor walking into the exam room, one patient, one problem, one at a time. This is very few of us are really trained to lead the team that Paul Grundy is describing.
Wow, I really like your example of this sort of command center. And I know here at Innovaccer, where we talk about data, we think a lot about command centers, but you're absolutely right. It's going to need a different type of leadership and maybe different team members as well. And we're going to get into that in a bit.
Good.
So interesting. let's take a little poll and ask our audience sort of how do they think about team-based care and how do they interpret that. So why don't we bring the poll up, and each of you can go into your GoToWebinar and enter. And while we're taking that poll, Dr. Nash, do you want to say a little bit about your thoughts about that system-level cockpit that you were talking about?
Sure. It's exciting because, like the others of us on the phone, this is year 30 for me as a primary care practitioner. I don't do any hospital medicine anymore. I've just been relegated to the office, and I'm very happy and comfortable being there. And yet, even at a great academic medical center like Jefferson, we don't really have too much of a team, I would say, in the primary care office. We're building it, and it's happening slowly, and it's being reinforced by good technology like Epic and other tools. But on reflecting on the last 3 decades of doing this, I think the new attendings, 2 or 3 years out of training, they're much more facile with the technology. They understand the role that other professionals play. They've trained side by side with nurse practitioners, physicians' assistants, case managers. So I think part of the challenge, David, is making sure people understand what each other's roles and responsibilities and capabilities really are. Most of us have been in a very physician-centric training environment.
Oh, I would agree with you completely. We've been really moving from a physician-centric to a patient-centered world, haven't we?
We're trying.
So let's see. Absolutely, we're trying to. Let's see if the poll is done. We can bring it up. And waiting just for the. So I really like looking at the work of Intermountain Healthcare, and we recently published in 2016, which really shows the impact of team-based care on utilization and cost. I think what's really interesting is that if we start to take a system-wide view of team-based care, we start to see not only improvement in certain quality measures, but also a reduction in utilization measures, a reduction in hospital admissions, ER use. We also see a reduction in overall cost to the system of care. So it's really important to start thinking about this team-based approach, both to a practice and to a system of care as we move into these value-based contracts into a world of population health management. So there's a lot of challenges when we start thinking about team-based care. Let's take a look at some of the challenges we might run into. So let's start with you, Dr. Grundy. What are some of the challenges you've thought about in moving from a traditional practice into a team-based practice?
So when I think about moving to a team-based practice, I started sort of the process point in my head. You know, we used to build cathedrals with a master builder who had a plan in his head. We don't build skyscrapers that way anymore. You know, we have a plan. We have an architect, we have an engineer, and we have the data that we're moving off of. I think one of the most difficult things that I've seen in moving to this model is really getting at the information, the source of truth, to be able to do like the architect, to really understand this tensile strength of steel and begin to understand, you know, how you manage across the team instead of in a doctor's head. That Flexner model that we all began to learn, where the data storage device was what was in the doctor's brain. It is one of the most difficult things to get across. That cultural change of thinking about continuous improvement that every other industry has done, the ability to have the communication and the data around that, and the training to do that, I think are just immensely important. We're beginning to see that happen, and when we see that happen now globally around the world, we really begin to see tremendous changes. I mean, my experience in the last decade in Denmark, we've gone from about 120 hospitals down to 21 because care is delivered at the primary care level. In fact, 93.7% of all care is done at the primary care level.
Awesome. So, you know, Dr. Nash, given your experience at the college, I'm sure you certainly have a great insight into the issue of leadership that's needed to drive that sort of culture change, not only at the practice, but at the system, and then the kind of training required. a few thoughts you have about what's needed from that perspective.
Sure, and thanks again. Yeah, well, from our College of Population Health perspective, we believe that our mission is to train leaders for the future. And they're going to go out and implement the necessary change. So how do you do that? Well, certainly part of it is content driven. So where is the system going? What are the forces that are interacting? What's the research evidence that might support making one change versus another? Basically empowering leaders with evidence-based data to drive good decision making. You can't underestimate how important that is. Experienced clinicians know that we have solid grade A randomized controlled trial data at the bedside 18% of the time, plus or minus 2%. In other words, 1 out of 5 decisions, we have pretty good science. The other 4 out of 5, not so good. So recognizing the level of the evidence, training for uncertainty, understanding the system's nature of care, improving communication, especially as it relates to reducing error and reducing complexity. So all of these things are critically important to us and are components of the curriculum across all of our online graduate programs.
Well, that's so important to understand. We've got a little bit of a time lag here, but I'm looking at the results from that poll just now, which many of you have seen. And what's really interesting is results were 88% care coordinator, 81% care managers, 77% integration of behavioral specialists, 73% pharmacists, and 72% community resource coordinators. So lots of new team members needed as part of that team. Dave, given those comments, how do you recommend that systems and practices think about bringing in all these new team members and forging these teams? How do they wrestle with this today, given these interests?
Well, here in Philadelphia, as just one example, we're seeing the growth of some of the venture-backed brand new primary care practices like Iora and Oak Street and ChenMed. I applaud all of these new models who recognize all of the characteristics listed on this slide, that the composition of the team, training the leaders, typically the physicians, practicing good communication skills and teaching people how to do that, transitions in care, sign-offs on the weekend, handoffs during the workday. I mean, we have always sort of assumed that everyone is equally good at these tasks, and the research evidence is overwhelmingly proves that that's just not the case. So every one of these organizations, ChenMed, Iora, Oak Street, they're committed to training physician leaders on these skill sets. I think that's a watershed change.
Sounds like there's a lot we can learn from their approach as well, and think about how we train our own folks as we move toward this new form of team-based care.
Well, we've always assumed that doctors were good at all these things.
No, absolutely. And, when we think about that, one of the analogies that comes to my mind is many people have pointed out that we're kind of like where the airline industry was 30 years ago, when it was very pilot-centric and yet accident rates were very high. And we know that aviation was an early adopter of team-based decision support technology due to the progressive digitalization of the cockpit, which is kind of like the digitalization of the office practice now and the health system. Flying for airline industry became very safe as people began to trust the data they saw, had decision support, and we know that that's so critical today for safe flying. In fact, the computer does much of the flying, however, with human oversight or intervention, as we've seen in some recent experiences that lead it to safety. So although healthcare is in the early stages of adopting these sort of new technologies like artificial intelligence and machine learning, it's starting to make some significant strides. And what we need to do, as you pointed out, Dr. Nash, is really change the culture through training from more of a physician-centered world to a more team-based world.
So Skelly, when he landed in the Hudson River, everybody declared him a hero. He said, "I'm no hero. I just have a system of flying that I rely on, and it's a team that does that." And that's the kind of thought process we need to get into in healthcare.
That's exactly right.
Yeah,
So given these challenges,
yeah, I would just add,
go ahead.
I think Paul brought up a great example. My hero in this arena is my good friend John Nance, one of the founders of the National Patient Safety Foundation, of course, now a part of IHI, but John's award-winning 2011 book, right, on why your hospital should fly, I think was a great Rosetta Stone book. It translated crew resource management for healthcare. And if you embrace a just culture, if you learn to go against the authority gradient without recrimination, that will lead to a better outcome. And I think it's incumbent upon us to teach these sort of tenets in training.
Great insight and lots of challenges for all of us. Let's take a look at what our audience thinks is the most challenging aspects for implementing team-based care in each of their settings. So while we bring that poll up, Dr. Grundy, how do you think about the challenges from education, training, culture change, leadership at a practice level?
So we're beginning to see a huge shift towards training our folks to think about relationship-based care. Again, in the Danish model, all the docs that start medical school, their first class is how to build a longitudinal relationship of trust. And then how do you build off of that in a very important, powerful way? I happen to have been at the University of Oklahoma, Tulsa, Dan Duffy, years ago when they changed their model, where we used to have four medical students banging up against a patient, learning how to do a chief complaint in the first year of medical school as just a clinical medicine. They now have a nursing student, a behavioralist student, a medical student, and a pharmacy student. So from day one, they're beginning to think about this as being a team sport and having the data not in your head, but just like building a skyscraper, it's in your EMR, it's in your technology, it's in your database. It's your source of truth that you're using and not your head.
That's a great point of view. So let's see if this poll is just coming to fruition, and we can send me the poll results. Just waiting a few more seconds. The poll results, but here they are. So 18% having a holistic view of patient information across care teams. Boy, having that cross-sectional, holistic 360-degree view is kind of there. Integrating care coordination in the team at 26%, 10% enabling point-of-care decision support for physicians, 25% for addressing social determinants of care. Boy, there's some interest there. And 10% engaging the patient into the process. Dr. Nash, what do you make of these results?
Yeah, this is about what I would expect. It's kind of all over the map. I'm impressed that social determinants and care coordination rose to the top here. That certainly supports our work in population health at the country's first such college, that you can't take this for granted, and the role that social determinants play in influencing outcomes is so critical, and the holistic view. So this is about what I would expect for folks to talk about. Very important part of what teamwork is really all about.
Dr. Grundy?
The Veterans Administration did a big study of thousands of patients in sort of year 8 of their moving towards patient-aligned care teams or their patients in a medical home element, looking at what are the elements of this concept that are making a difference in quality. And what came out top was care coordination. And what came out second was access, which I think is really important.
Fascinating. So, sounds like the country's moving ahead, lots of challenges, lots of different interests in different types of teams, so exciting. So let's go back to how do we approach this, right? We're all at a different point, we're trying to embark, we're sitting on a dock and our boat's getting ready to leave, we're starting to put the team members in it, and starting to get some tools to move ahead. I really like the approach that our friend Christine Sinski, Dr. Christine Sinski at the American Medical Association, has put as her step forward module to really think about how do you move into a team-based model. So first is particularly if you have a large practice or a system of care, is engage a transformation team, build the leadership that's going to really enable the culture change that's required. Think about defining who your team members are, strategically redistribute the work, and then bring in some data that you can share, enhance the communication connectivity amongst the different players, the care managers, care coordinators, pharmacists, et cetera, so they can all start operating as one team, just as a pilot does when they're connected to air traffic control, to the back flight crew in the back, the flight command at a different site, and to the other aircraft pilots. And then optimize your care, right? Learn iteratively over time as to how to optimize that team and the performance of that team. So let's quickly go through that, and then I want to ask our esteemed panelists some questions. First, you want to engage a transformation team, right? Bring together a multidisciplinary team with a leader who's got enough authority to empower it, choose the right technology to support them, and consider involving patients in that care team as well. We're going to get into a story about this in just one second. We want to organize that care team not just as a core team, right, which traditionally is maybe a physician and a clinical assistant, like a medical assistant, maybe that's a nurse or a health coach, or maybe something else. Then the extended team, which could be embedded in the practice, or it could be a shared resources across practices, such as a care manager or care coordinator or a behavioral health consultant, depending on the size of the practice and the aspect of the system of care you're clinically integrating across. And then also think, as we think about these social determinants of care, who are the affiliate folks you want to bring into that? Could be formal links with community agencies that are providing different care to members in the community for specific things, such as a YMCA providing diabetes support groups, et cetera, et cetera. As we think about the composition of care teams, particularly as we move into the community, Dr. Nash, can you give some examples from your experiences as some unique examples of how communities are starting to address this with practices and health systems?
Yeah, I want to go back to the three organizations again, IORA, Oak Street, ChenMed. I think they're the model looking forward of using different kinds of team members. The way they start their day, looking at the roster of the patients who have appointments that day, they sit as a team huddle in the morning asking themselves the paradigm shifting question of, well, what patient, who is not here today who ought to be? So instead of the RVU-based, gerbil on the wheel production function that I'm so accustomed to, they start the day asking, well, hold that wheel for a moment. Where's Mrs. Jones? She's not on the schedule today, but the artificial intelligence in our technology enabling practice program here is telling us that the last two sugars were abnormal. Now she's got sugar in her urine, and we haven't seen her in 4 months. That's just a totally different view of the world. And it goes back to where we were 20 minutes ago. The technology enabled teamwork and physician leadership to get the other folks on the team to say, bring me this data and let's turn it into information together. I think that's going to exemplify the practice of the future.
Very good insights from those examples, and I think there's a lot we can learn about partnering and also using technology and working together as a team in this regard. I think the other piece is we really need to build a leadership that drives the culture change, so once people are connected, they learn workflow and other processes to work together instead of working as independent providers in a healthcare system. And then we start to think about how do we strategically redistribute that work amongst the new members of the team. And who do we give to community agencies that are rising to this? What is the role of the behaviorist and how do they get engaged? How does the pharmacist get engaged in the care plan process? That's pretty unique. Dr. Grundy, I know you've had a great example from your work at the University of Utah where you're in the faculty around how they redesigned primary care in their office. Could you share us a little insight about that?
So 12 or 13 years ago, the University of Utah was the very first academic medical center that adopted the patient-centered medical home, the care by design, Bodenheimer model of care into its practice. And we went to a model in which we designed the whole flow of the clinic such that there was really no waiting room. We have 2.2 MAs for every physician, every clinician, and the MAs drive a lot of the care. Interestingly enough, we took our beginning entry of medical students and we put them through the same training program as our MAs. And so they begin to get that whole flow process. So what happens is the MA will pick up a patient as they walk in. They will begin the process of organizing the care that's needed for them that day. And then when the physician walks in, they'll walk over and they become the scribe. That takes this burden of typing off of the doctor's head, the clinician's head, and moves it to where it should be. And then oftentimes it's just a little encouragement because there is no difficult diagnostic dilemma to sort out. It's just sort of blessing the relationship. And the physician will say to the MA, you're gonna go with our patient now to the nurse educator who's going to spend some time designing their diabetic educational plan or whatever it is, or you're gonna go with the MA to the to the clinical pharmacist who's going to help you with your medication plan. So it really forks off. It really drives efficiency and effectiveness. The average time spent as an MA in that system, these kids come right out of high school, is 3 years. And we now have our 13th physician who started as an MA, got their associate's degree, went on, finished their bachelor's degree, and finished their training at the University of Utah. And most of them are actually working right in those clinics where they started as an MA. It really changes the system.
So that is fascinating. So no waiting room?
No waiting room.
A medical assistant just escorts them to where they need to go. You efficiently get some work done prior to seeing the doctor. The doctor's in the room, but not working on the EMR. They're talking to the patient. Fascinating. And they have someone else doing the internal input for that EMR with them, which I'm sure they'll oversee. And then that same person will escort them to the other components of the practice that they need.
And coming into the room, by the way, they will already have their clinical results from their laboratory tests that needed to be done. That will already be in the record because the system is designed to be efficient that way.
Fascinating. Dr. Nash, we've heard a lot of talk lately about how physicians are spending so much time typing in the EMR, not looking at their patient. I've even heard the phrase the tyranny of the EMR used as it leads to what many people call physician burnout. Any thoughts about or experiences about how to address this dilemma?
Sure. Well, I have two ideas in this regard. One, very recently in the last few months, I've started to ask patients to come and look at the computer screen with me and to double check. I use that as a sort of a ruse to double check what we have on them is correct. And when they see the screen and they see the level of detail, generally speaking, they're pretty impressed. And I show them notes and other details from other consultants and subspecialists. So very quickly, I think getting patients to see the screen, literally view it together for a minute or two is very powerful. But I think let's not kid ourselves. The electronic medical record is just that. In other words, if it's just an electronic version of the chart, that is not moving the ball down the field. What I'm interested in our degree in population health intelligence is all focused on is the registry function that the EMR brings with it. In other words, I hope I'm still around practicing primary care medicine in an era where I could ask the computer a pretty basic question, which goes something like this: how am I doing? How am I doing in the care of my patients with, in my case, diabetes, heart failure, chronic obstructive lung disease, coronary disease, bread and butter primary care? How am I doing? Imagine if we could answer that question relative to the local peer group, a regional norm, a national standard, whatever you like. I've called this Registry 1.0. So I just want to correct what you have here, that sure, the MA may operate the EMR. I get that. That makes sense. But the physician, she needs to operate the registry. Very different construct.
Yeah, I think those are great insights. You know, you brought up a couple key points around the culture change we're experiencing as we move into this new world. One is the idea of bringing the patient into the process of documenting the record and learning about that. You know, I actually worked with some practices back when we were, Dr. Grundy and I were at the Patient-Centered Primary Care Collaborative, and I remember one practice where the leader wanted to go to an open notes, opening up their patient records to the patients, and the other members of the practice were livid, saying, "Oh my gosh, that's so dangerous, you don't know what they'll do, they won't handle the information," very resistant. Eventually that leader won.
Yeah.
They opened up the records, and I still remember him telling me that one of his fellow practitioners walked in a month later and said, "You know, not only was that a good idea, but I don't know how I ever live without it." And
Wow.
he asked, "Well, why do you say that?" And he said, "Well, because my patients came in and said, well, I don't know that I'm on these medications. And by the way, did you know I had surgery 4 months ago? I don't see that in the record." So it's suddenly, you know, this is the interesting thing about culture change is people are resistant, but once they sort of get over the hump and kind of get the value that we're talking about, it really changes things.
Well, Tom Del Banco at Harvard Medical School has some classic scholarship in Annals of Internal Medicine describing exactly what you just discussed, David Nace. In the primary care general internal medicine practice at Beth Israel in Boston, the struggle they had to make the notes open and the reward that most of the physicians felt they got downstream from such an open note. And there was resistance and screaming and yelling. And, you know, years later, good measures of improvement in outcome based on improved communication.
So we're now in our 12th year in Denmark, where it's a two-screen approach to the interaction with the doctor. So the patients have a screen that they can see that's going on with their records. Real-time information like Innovaccer can provide is available, and everything by law goes into the patient's portal, and they have access to it. It's entirely open. It really is exciting and interesting, and it allows any other primary care doc to cover for your doc if they're away, because they just get permission from the patient to access their records.
Wow, really exciting discussion. I'm sure we could talk about this forever, and I think our audience is gaining a lot of information. Before we move on, let me just tell you, as we move to the point of having you, the audience, be able to have your questions submitted so we can take a look in the last few minutes of this webinar, please go into the chat box function in your GoToWebinar and enter any questions you have, and we'll get to answering those questions as we move on toward the latter part of our webinar. So with that said, I really want to pick up on some things that Dr. Nash said around the technology in enhancing the communication and connectivity. So, Dr. Nash, as you were describing this, I was thinking of a world where there isn't somebody documenting in the EMR, but rather you have like an Alexa type environment in the waiting room in which the patient and the doctor are talking, and that information is being captured and downloaded in some form of structured and semi-structured way, so it turns into useful information through artificial intelligence. Great future vision, maybe not that far away, and maybe the same type of thing in the home where the doctor visit is occurring in the home. So that's the way we sort of envision the future of things here in Innovaccer, and we agree with you that the EMR we see today is not what we expect to be the technology for the future. I think I really like your point of turning to the concept of a registry not as a software package or a separate downloadable instrument or an installation or an EMR function. It's a function that you just need to have in terms of being able to ask questions about specific populations and specific types of patients. So I applaud you for that.
Great,
so
thanks.
I think, absolutely. I think one of the most important things we talked about in our open note discussion is that patients need to understand who are the members of their team, know that they have the ability to communicate with them, and be a part of that data sharing platform and that information sharing platform. So they all have actionable information at their point of care, which for them is in their home and in the community. So I think as we continue to talk about some case studies and rethinking of different team members, I want to bring up a point I had working with Dr. Rashika Fernandez-Pulley in his early days before he formed Iora, which you pointed to, Dr. Nash, where he was working in Atlantic City and taking a risk-based contract for the highest risk patients only and going at full risk to do that. And they thought the best way to do this is put lots of different team members at it and hire the most credentialed health professionals to do that. So they brought in people recruited from multiple states, the highest academic institutions, and put them on as care coordinators and health coaches and educators. 6 months into it, they weren't getting the results they expected. And they did something very innovative. Dr. Fernandez-Pulley said to me, you know, David, I decided that we should bring our patients in and ask them why this isn't working. And they did that. They formed a patient volunteer council, which ended up becoming a permanent member of their strategic advisory group. And they asked them, what do we have wrong? Why isn't this working? And they heard loud and clear, the people you're hiring don't understand us. They don't know us. They don't know our community. And he took a leap of faith on that. And they started to ask the patients, who should we hire in these roles? And they would point to people in their community, young people, people that didn't have the sort of power to go to a great college and get that educated. They would say, oh, Sheila, she works at Burger King. She's super smart. She speaks 5 languages that are in the community. She knows everybody. She's a social connector. Her family doesn't have the money to go to college. Bring her in. She'll know how to reach us. She'll know the community and the people. And suddenly, when they did that, it's funny. I went there 6 months later, and I saw these folks doing a report out on the team. I could not tell that they weren't nurses because you can train people to do this sort of presentation and provide the oversight needed. And their results just began to soar. And that really led to the eventual formation of Iora. But I just want to open the door for the two of you. How do you think about how to think out of the box in taking this approach to rethinking team members? Dr. Nash.
Well, again, I'm a real proponent that these teams have to be created, they have to train together, they have to have resources that are allocated. You know, there's the old gag that doctors think that golf is a team sport, or better yet, in a football analogy would be, you know, every doctor is a quarterback. Have you ever seen a team of just quarterbacks? There's nobody to receive the ball and nobody to run the ball. And so, again, at our college, we're pretty pragmatic about aspects of this, that the team approach to care means exactly that. Who are they? Are they trained to work together? How do they get better outcomes? Grafted on top of the technology as described, most especially the registry function. I still want to come back to that as such a key piece of enabling technology. And now I've described registry 1.0, 2.0, and 3.0. I think 2.0 in the office would be, as Paul Grundy knows so well, is harnessing artificial intelligence in the ambulatory setting, and then getting information from the iterative system that says Mrs. Jones should be on the schedule today, and she is not. You're seeing Mrs. Smith when a nurse should be seeing Mrs. Smith. You need to see Mrs. Jones, and here's 5 reasons why. I am so excited. I hope I live to see that.
So I think the ultimate in population health, and the way I think about it, is every patient in that population has a plan. It could be a simple plan, like my cat has, that gets reminded it needs its immunization. Or it could be a really complex plan with somebody with 5 organ systems that have disease that need a care coordinator and home visits. But you know, that process is one in which everybody has a plan. So you're managing your population down to an independent, moving away from delivering an episode of care to delivering a plan for every citizen is really exciting. One example of that third element you talked about in an extended team is those that are sort of offshore. And in the Blueprint for Health in Vermont, they took 2 cents out of every sick care dollar, and they created the role of a community coordinator, so that my newly diagnosed diabetic is introduced through the community coordinator, taking that burden off the doctor, to the diabetic hiking club that meets on Saturday, to the nutritionist in the grocery store, to the 36 not-for-profit agencies that exist that can create a plan not just for sick care, but for health care across that whole community. I was sitting in a meeting in St. Johnsbury, and a young Anglican priest says, we're never again going to have a diabetic suffer an amputation because we don't have, as a community, a plan wrapped about that patient. And they've seen a 60% reduction in the complications of their diabetes, 60% less blindness, 60% less amputations. I mean, it's a great success story that I think should be duplicated.
So some interesting discussions around how for every practice and for every health system, who the members of the team are, what technology they're using, how they're using it, is not only, a work in progress for them, but also highly varied depending on the practice, the system of care, the communities they're in. What are important principles in optimizing the care team are streamlining the processes across teams, bringing in automation, bringing the technology to provide decision support. These are things we've learned from the airline industry and certainly things we pay great attention to in our designs here at Innovaccer. And then engagement tools, engaging each member of the care team and each member of the patient in their care team. It could be eventually a patient's family member or a friend that they see are critical in their care process and want to be involved. And then learning that process management, making sure that patients understand this new model. It's not all about the doctor and everything's done by the doctor. And that all the members of the team are constantly kept informed of each and every one's activity, and it's all orchestrated. We often talk here at Innovaccer about we creating an orchestration engine, an engine that not only provides the sort of integration of information and real-time support for the players, but also orchestrating the workflow of the various players, including the patient and their caregivers, around getting the best outcomes for care in the most efficient way possible with the best access. So all of this, as we pointed out, requires a lot of new training for the team and maybe even a new breed of professionals. Dr. Nash, I know this is so deep to your heart. You've spent 25, 30 years focused on this, training physician leaders, building the College of Population Health. Let's kind of sort of bring us to the point of talking about what are the needs of the types of people we need now to be health professionals, and what are their training needs, and how do we think about incenting them as teams?
Wow. Well, I just returned from an overnight flight from teaching my 25th anniversary at the American Association of Physician Leaders. I do my all-day intro program on the fundamentals of quality and safety with 100 brand new physician members of AAPL yesterday. So I could speak to this within the last 24 hours. It's just super exciting for me, even as an old guy, to still get out there with 100 brand new emerging physician leaders 4 days into their formal training. Most have had no exposure to any of the issues that you and Paul Grundy and I are talking about. I mean, it's remarkable. And these are not 25-year-olds. These are 35 to 50-year-old docs, all at the attending level, who haven't had a single day of formal team training, systems thinking, the root cause of error, closure of the feedback loop, non-punitive feedback about individual doctor performance. I mean, it's just remarkable. So look, my glass is half full. Otherwise, I think I would go crazy, because my view is we have a lot of opportunity here. And if you could then use enabling technology like Innovaccer, imagine if what the next version of Innovaccer is going to be able to do, and use the predictive analytics and give doctors good information to show them where they are. So everybody knows the story. If you teach somebody how to fish, it's a lot better than just giving them the fish. That's what I was doing yesterday, teaching them how to fish and using the tools.
I really like your analogy of how you come into practice each day, and the three things you want to know is who's here and what do I need to know about them, who's not here and what do I need to know about them, and how am I doing? And I think that's the part of continuous learning we all need to get from. There's one other piece here, though, and that's the way care is paid for. So we have our first question that's come in as we move into our questions and the answers for the panelists from the audience. One participant said, they have a serious challenge in the industry. Hospital-centric leadership and decision makers would be named as the greatest challenge from their point of view. And I know that relates. I know that relates to the incentives. So let me start with Dr. Grundy and then come back to you, Dr. Nash. Dr. Grundy, I know you've thought a lot about how payment influences the way people think and act. So a few questions and thoughts on the answers to that question.
When I first started this journey, I was driving into a large city and there was a big sign on the road that said, "We do the best heart surgery in the state." And I met with that CEO and I said, that's not what I want to buy. I know exactly what you're saying. You're saying we know where the money is and we're going after it. We can buy a pretty good amputation for our diabetic. That's pretty easy to do because that's an episode of care. But what I want to buy is 1/3 less need to do heart surgery. That's aspirin, blood pressure, cholesterol. That's managing a population. There's fundamentally only one way to hurt a cat, and that's to move their food. If you're asking a hospital and you're asking a delivery system to manage a population and you still continue to pay them to do an episode of care, you're going to continue to get episodes of care. So what we're beginning to see happen, not only here but globally, is that we're moving towards a whole different mechanism of paying. I was just at a meeting in Washington, and our Secretary of Health and Human Services says we cannot move away from fee-for-service fast enough. And so the challenge to everybody listening to this is how do you begin to transform towards population health when you know that that's where your payment's going to be in a short period of time, but you're still being paid predominantly in fee-for-service world.
Dr. Nash, I know I've seen your slide with a physician or a hospital administrator sitting with a foot in two different canoes.
Right.
You're in a large health system. How do you think about this?
Well, Paul Grundy's exactly right. We're in this trough period. No one knows the exact date. There's not going to be a flip of a switch to go from volume to value. What do we know? Well, by 2020, 60 cents of every Medicare dollar is going to be connected to an outcome measure. What else do we need to know within the profession? That if 60 cents of every Medicare dollar is connected to an outcome measure, we better be paying attention to those measures and how to get there. And the only way I know is by changing the economic incentives and give doctors good information about their own performance in a non-punitive way delivered by a peer and teach them how to improve. If you do all three things, align the economic incentives, close the feedback loop, train on how to improve, then you got to get out of the way because doctors will stampede to improve.
It's so funny because all of the questions that I'm reviewing that are pouring in are around this issue.
Sure.
How are you able to make the change in investment starting from volume-based to value-based to an operation? What's required in the investment, leadership, engagement, culture change to make this change? How do you convince health systems to start this team-based care with primary care as the base? All these questions are very similar.
Yeah. Well, I think David Nace, if I might, just for a second, I totally appreciate and feel this in a visceral way. So as I alluded to, yesterday was double APL on a Sunday. Saturday morning, I was at Novant Health System, Novant, an amazing multi-state, thousands of doctors, North Carolina, Virginia, South Carolina, an incredible team. What was one of their distinguishing characteristics so relevant to this conversation? An incredible system-wide commitment to training physician leaders. And their CEO is a non-clinician, Carl, right? And he is so smart because he knows to get them aligned with value-based payment, they've got to train a cadre of physician leaders across the enterprise. So look, we could do this. It's a matter of leadership commitment and not waiting until the platform is engulfed in flames. Everybody's platform is smoldering with smoke. Why should we have to wait till it's actually engulfed in flames before we make the appropriate change?
That's right, the burning platform. Dr. Grundy, as we move toward the end of this webinar, do you have any final thoughts along this line for these questions?
So I'm sitting here at a hospital system in Ohio that 10 years ago began using their own employees as the place where they learned how to manage a population from. In most cities in the United States, most hospitals are probably the largest employer in that community. And I've experienced now probably a dozen or more communities in which the hospital as an employer began managing its own employees. That's their cost, right? You know, that's their pain as in every other employer. And then they go out to the school board and they offer that same solution to them, which has been a very successful model. In addition to 60 cents out of every dollar from the federal government going towards management, there's a huge movement, the Healthcare Transformation Alliance, in which, you know, most of the Fortune 100 are asking the same thing to happen with their employees as well. So it's not just government, you know, directing towards a change in payment way for fee-for-service, it's the employers as well.
Yeah, that's just so well said by both of you, and this really provides us some great insight. I think as we come to the end of our webinar here, I just want to provide a summary, and certainly this is the way we think about things at Innovaccer. We look at that healthcare data platform as the bottom, the foundation for which all these things are built. So thinking about how do you engage a patient and a provider, how do you seamlessly coordinate things amongst the different players in the system, how do you provide actionable insights for them, and how do you make the whole thing more efficient so we can move from a volume-based business to a value-based business, get more efficient, get more economy in our care, get better access, and really provide better solutions. So I think I want to thank both of you for just a wonderful dialogue. I want to also point out to the audience that episode 4 will be coming up in November about how to modernize practices. We're going to talk a lot about automating the primary care practice and automating healthcare systems so that we can really make things more efficient, both for the patient accessing care and for the provider, so they can spend time on the relationship, thinking about empathy and compassion and listening rather than typing into the EMR. So really excited about seeing everybody for that. But at this point, I want to thank both of you. Dr. Nash, thank you so much for attending, and thank you so much for advising us here at Innovaccer with your great insights.
Thanks. Great to be a part of this. Special thanks to my good pal, Paul Grundy, and to you, David Nace. And I want to know, will all these 4 episodes be available for binge watching on a weekend?
Of course they will, and we will make that available. We'll provide the link to people after this episode. And we'll even talk about if we can talk to Netflix about getting it.
Outstanding. Sign me up.
Dr. Grundy, thank you very much. You're my good friend. You're here in the room with me. We've actually been out here working with a hospital system together, providing Dr. Grundy's great advice and experience and thinking about things as well. And thank you very much.
Thank you. And Dr. Nash, thank you for your leadership in population health. It's meant so much to our country. And
thanks.
I always enjoy being engaged with you.
Thanks so much. Really fun, you guys.
Gentlemen, thank you so much. And till the next episode, take care. And thank you very much to the audience for participating. This concludes our webinar.